increase the rate of mastectomy. You agree on that? It is just in front of you that we have inherent difficulty to define tumor margins in lobular cancer.
I think this is true, but I would rely on my pathologist. If the pathologist tell me you have done a resection and your margins are clear, then I would proceed with further treatment accordingly, and definitely these patients are going to need radiation. I want you to think that by doing lumpectomy, we are not sterilizing the breast from tumor. Let's snap this out of our mind. We surgeons thought that by doing a lumpectomy, we're completely clearing the breast from disease. The answer is absolutely not. We are not clearing the breast from the disease. The Holland trial, which took mastectomy specimen, was presented today in one of the sessions, shows that at least 66% of the patient have disease beyond 2 centimeters of resection around the tumor. So we know we're leaving disease behind. We think that the treatment, these mostly are luminal A, they are very sensitive to hormonal treatment, and perhaps the hormonal and the radiation will do a good job. And that's why, if I have negative margins, I'm okay with it.
Then my question to the pathologist, do you have a problem to define the margins in lobular cancer more than carcinoma, for instance, or for you it is the same to define the margin?
Well, margins can be defined because you have the pathologic examination of the specimen, and if you're careful, you can define it and you detect the tumor cells. This is not the detection of tumor cells at the lumpectomy specimen. This is the whole nature of lobular carcinoma, as whether the areas that you're looking may not really have anything, and your pathologic diagnosis is correct and your report is correct. But it doesn't mean that if you millimeter or centimeter from that main targeted lesion, you don't have multicentric or the multifocal disease. But as far as assessment of the tumor margin, infiltrating lobular carcinoma is not really different from infiltrating distal carcinoma. We can tell you.
There's no overdoing of anything extra for the lumpectomy specimen of lobular cancer. That's the question for us.
Well, at least this is my experience. I think the other people can, express their opinion.
The other pathologists across the globe.
So one thing to remember that compared to other types of invasive carcinoma, invasive lobular carcinoma can be very hypocellular. This may create problems, especially for intraoperative evaluations. So if you are doing surgery and if you are doing frozen sections for your lumpectomy margins, the false negative rate of margins in invasive lobular carcinoma can be higher because these tumors can be very hypocellular. Other than that, there is no importance of invasive lobular versus other types of invasive carcinoma. Pathologists need to know this, and same thing is true for evaluation of sentinel lymph nodes on a frozen section. Metastasis of invasive lobular carcinoma can also be hypocellular. So that is the importance of it.
So still, without the frozen, without the paraffin section final, you're not really sure about your primary report intraoperatively.
False negative rates usually are higher.
Okay. You wish to add anything? Okay. Thank you. Okay. So that's the kind of data we have in the literature, whether local recurrence is more following mastectomy or following receiving surgery. Of course, they are not randomized trials. They are retrospective analysis in the majority of reports, and we can see, with the exception of one report only, the vast majority, especially this huge study of more than 21,000 patients, did not find a difference between mastectomy treated and this conservative surgery treated in terms of local recurrence. A final report from our surgeon and from the radiation oncologist for this recurrence rate. We start by the radiation oncologist, Dr. Fadi Jahar.
Okay, I fully agree with this summary. In our clinic, we never really consider a lobular carcinoma as different from invasive ductal as far as the validity of conserving management using radiation therapy. And all the studies, and as you said, most of them, and actually all of them, are retrospective. They could not find a difference, and therefore in our management and our thinking process, we treat lobular carcinoma the same way we treat invasive ductal as far as radiation therapy.
I wish just to remind everybody that we don't have a real prospective studies in lobular cancer, so all the data here will only depend on retrospective data. Mahmoud?
I fully agree with that statement.
Okay. So, the St. Gallen, we have just heard that the consensus, which is almost, it's hardly seen like this, the vast majority consider that the lobular histology is not neither a relative or an absolute indication for mastectomy, which is very much in line with what we said. And neoadjuvant chemo is an effective treatment in lobular cancer compared to ductal carcinoma. This study I borrowed from you, Mark Spillman. You presented in our conference something like 7 years ago. And I think you are the best one to comment on that. That is the neoadjuvant chemo at the era when we used to give chemotherapy for everybody. Okay, what kind of messages you see here? That's the ductal carcinoma, that's the lobular carcinoma, and that's the PCR rate, of course, higher here. How do you wish to say? That's a French study, by the way.
We are sure the lobular carcinoma are not very chemosensitive, okay? But we can see 1% in the 1% of PCR, okay? And the other part is 3%. It's not negative. And for this reason, I think it's not possible to do neoadjuvant chemotherapy, but chemotherapy adjuvant probably may be considered if we have lymph node positive.
Okay, thank you. Joseph.
Hamdi, we have to be very careful when we discuss about the neoadjuvant approaches and the end point. Once again, the discussion at the beginning was, if the lady wants breast conservative surgery, do you think that the neoadjuvant approach is okay? And do you think that in that case, chemotherapy might do something? Honestly, to answer the question, nobody knows. Everybody is looking at the PCR, but the true question is, what is the rate of conservative surgery you obtain after neoadjuvant chemotherapy in infiltrating lobular carcinoma?
Absolutely.
And the answer is, we don't know.
Yeah, absolutely.
The other point is that even PCR is not a prognostic factor here, because they are closely, as you mentioned before, to luminal A. So we can have a lot of discussion, but it will never help us. One question I want to address to the surgeon, it's, will you consider, even if you think about neoadjuvant endocrine treatment, a sentinel lymph node first, before endocrine treatment? And if it's positive, will you still consider to begin with neoadjuvant endocrine treatment or not?
So you did not attend my talk because you were in another session. But I would definitely do the sentinel node after. I wouldn't do it first. There is one study that I'm aware of, and that study is, I think, an Austrian study, and I don't recall in which paper, which journal it was published, that they found the use of neoadjuvant chemotherapy did not achieve a pathologic complete response except in probably 2 or 3% of the patient. However, the decrease in the size of the tumor was adequately enough to increase the breast preservation by 50%. However, this is the only study that I'm aware of, and I have not seen any other study in the literature. We at Sloan Kettering, we tend to favor not giving chemotherapy, neoadjuvant chemotherapy, to patients with invasive lobular carcinoma. The only thing that we may consider in this patient, that her Ki-67 was 67.5%. So this patient has a very high proliferation, and therefore they may be responsive to chemotherapy because the cells have a high proliferation. Having said that, the ideal way of proceeding with these patients, if we want to do neoadjuvant hormonal treatment, is to start the patient on neoadjuvant hormonal treatment, wait for 1 month, and repeat the biopsy and look at the Ki-67. In the study that have been published from the ACOSOG trial, if the Ki-67 drops from 67% to less than 10%, then we know that the patient is responding and there's value in continuing neoadjuvant hormonal treatment. If there is no response and there's no drop in the Ki-67, then the value of continuing with hormonal treatment is probably negligent.
Joseph, you wish to add anything here?
Do I agree? Yes, about what? The approach with the biopsy?
Neoadjuvant treatment, neoadjuvant chemo, we've seen that pathological complete remission is very low in lobular cancer compared to ductal carcinoma, and nevertheless, for patients who do not achieve pathological complete remission, in lobular cancer the prognosis is quite fine. In ductal carcinoma the prognosis is much less, and this was seen even if you consider only the ductal carcinoma with hormone receptor positive. So is that something unique for the disease response or unique for the prognosis of the disease?
So, I mean, this gives you maybe an information about the prognosis a little bit, but you have also to be very careful. In the MD Anderson study, when they have looked at the general follow-up of infiltrating lobular carcinoma versus ductal lobular carcinoma, if you put the cut-up of the follow-up at 5 years, you see that it's better to have a lobular than to have a ductal one. Just go through the 10 next years, and then the curves are crossing. That means that what is probably most important in the lobular is the duration of the control of the general disease, if you think that is a general disease. They are probably more endocrine sensitive, but also you need probably to prolong the endocrine treatment in this situation. So it's why I think that the neoadjuvant results do not give us a general information regarding the prognosis of this disease, but just an information regarding, in general, if it's better to have an endocrine or chemotherapy option.
So the message which I hope we can have time to cover, but it's very important by Joseph, that lobular cancer is a disease of late relapse. Lobular cancer is a disease of late relapse. Yes, please.
If you go back to the previous slide where you are showing a difference between lobular versus ductal and trying to make that this is because of the histologic type, it's a little misleading. Because majority, 68%, since
I'm not trying.
No, because I since I know the study very well because I'm one of the authors, and 68% of those ductal carcinomas are high-grade lesions. So if you look at the low-grade ductal carcinoma versus invasive lobular carcinoma, the difference might not be as dramatic. So this is not really because of the histologic type. It is more reflection of nuclear grading. So low-grade ductal carcinoma versus invasive lobular carcinoma, the response to neoadjuvant chemotherapy is not that different. As you will show later with molecular classification, which is also more correlates with nuclear grading or architectural grading than the histologic type. So to say that there's a major difference between ductal versus lobular carcinoma, you really need to be very careful because majority of ductal carcinomas here are high-grade tumors. So a more accurate statement would be, in general, low-grade tumors, which are low proliferation rates and ER positive, they do not respond compared to high-grade ER-negative tumors.
Yeah, but now we're discussing the lobular cancer, so we have to give messages for lobular cancer. You are trying to get into the reasons why lobular cancer. That's what we are trying to discuss here. Okay?
Okay.
Thank you for the great explanation. That's the gene expression profile, and I need one of the pathologists again to give us their opinion about the gene expression profile of lobular cancer according to this study. That was part of the big 98 study. Who wishes to give a comment? That's European part?
So, lobular carcinoma, and we had presentation also this year in San Antonio. They are typically of luminal A pattern in terms of gene expression. And as you can see on this slide, less than 20% of luminal B. We had a big presentation this year in San Antonio by Christophe Sautiriou team, which was the presentation was given by Christine Desmet, and they identify different pathways that were expressed in lobular carcinoma, giving us different therapeutic targets, especially in the ACAT pathway, but also looking at mutation in estrogen receptor in relapsing tumors.
That's for lobular or for luminal A disease?
For lobular carcinoma.
This means that histology counts.
Yes.
So, okay. Anyway, in our own material, which we just published a few months ago, we found by immunohistochemistry again that the majority of lobular cancer was luminal A, and the minority are of the other subtypes. But amazingly, we have 10% of triple-negative breast cancer, which was a little bit high in our series. That's the study Mahmoud mentioned about the neoadjuvant hormonal treatment in strongly positive. It was not segregated as luminal A and luminal B at that time. It was ER highly positive breast cancer, and that is one of the studies that showed that we have high conversion rate of patients originally considered by the surgeon to go for mastectomy, and how this was changed after neoadjuvant hormonal treatment. You wish to comment, Joseph? Joseph? At baseline, that's the amendment study, okay. The neoadjuvant treatment. At the baseline, we have around 50% of the patients classified as candidates for mastectomy. And after neoadjuvant treatment, you close the door here. Can you give us just 2 minutes? We'll conclude.
So this is clearly an important study because, as we mentioned several times during the meeting, actually neoadjuvant endocrine treatment is not considered a standard of care in all the situations. The level of evidence is not one. Before this, I think that one of the very important trials was provided, it's a small trial provided by UK and another one trial provided by a Spanish team, the JCAM. They have just looked in phase 2 trial on 2 approaches, chemotherapy versus endocrine treatment in neoadjuvant setting, and they just look at the cutoff of Ki-67 or the proliferation and looked at the response rate and clearly the way that can provide breast conservative surgery. One of the trials was published in Clinical Cancer Research, if I remember well, and the other one in Annals of Oncology. And clearly it makes sense when you want to decide about the way you will treat the patient to look at the proliferation. That might be one of the surrogate marker of chemosensitivity or, on the contrary, endocrine sensitivity. But endocrine sensitivity means first to have a high level of endocrine receptor and then potentially not to be chemosensitive and to have a low proliferation rate. Because you have some tumors when even if you don't have very high rate of proliferation, you are not very, very endocrine sensitive too, because the level of endocrine responsive is not so important.
Level of endocrine ER receptors, you mean?
Yes.
Yeah. Okay.
It's pretty rare, but you might find this kind of situation. So the trial is very important because, once again, it just gives us information that 1 is feasible, 2, you might achieve what you want, what you expect, so to have a conservative surgery, and 3, it seems, but we need longer follow-up, also to have clear not only safety profile but maybe disease-free survival that is correct and according to what we expect.
So it's very important to convey the message very clearly that neoadjuvant hormonal treatment is now considered as the real treatment for ER highly positive disease, HER2 negative, whether it is lobular or ductal carcinoma. Everybody agrees on that, the oncologists, the treating doctors, and the surgeon probably will also agree on that, definitely. Yeah.
Let me make a comment about neoadjuvant hormonal treatment. When you compare neoadjuvant hormonal to neoadjuvant chemotherapy, the chemotherapy response is usually quicker, much quicker than the hormonal therapy response. And it may take 3 to 4 months to have a significant response. Michael Dixon had published data on invasive lobular tumor who have responded to neoadjuvant hormonal treatment. I think he used letrozole in that group of patients. I'm not sure if it was letrozole or anastrozole. And he reported that you need a minimum of 3 to 4 months to achieve a significant response. So if you are planning to go that route, you need to take time in watching the patient. Now, having said that, the group in the U.S. who have done that trial recommend that you repeat the biopsy and confirm that the Ki-67 is dropping before you continue that neoadjuvant hormonal treatment.
You repeat the biopsy or you examine the graft?
You repeat the core needle biopsy and look for the Ki-67 and look at the change in the Ki-67.
Yeah, but I think by all means that's not standard of practice, definitely.
That is not a standard of practice, but this is, if you want to go that route, there are some data suggestive that this route may be helpful.
Okay, that's the St. Gallen. They told us that if you're going, exactly like mentioned by Mahmoud, if you're going to give neoadjuvant hormonal treatment, then it is not a 3 to 4 month course. Probably you need a longer duration in the range of 6 months, probably, or more in some cases. The patient decided to go for breast-saving surgery, and we have breast conservative surgery, and the biopsy again is ductal carcinoma, lobular carcinoma, with a surgical margin of 6 millimeters. Are you satisfied with this margin? Again, the question for the surgeon and radiation oncologist. Fadi, are you satisfied with this margin in lobular cancer?
Yes.
That's the St. Gallen. The St. Gallen does not really differentiate in surgical margin between lobular and ductal carcinoma.
Yeah.
Do we really need to segregate here?
No.
Or a negative margin is a negative margin?
Yeah, a negative margin is a negative margin, and we recently saw a nice consensus report from the radiation and the surgical community published less than a year ago now, where there's no difference. You don't make a difference between lobular and invasive ductal. The most important thing is to have a negative margin.
The ASTRO and ASCO guidelines, when they looked at the analysis, meta-analysis that was published in the Annals of Surgical Oncology in 2014, followed by the meta-analysis by Dr. Husami, they found that the histologic type of invasive lobular carcinoma should follow the same criteria as invasive ductal carcinoma, and you do not need to have wider margin for an invasive lobular carcinoma.
Okay. So we do not have to worry about the margin, extra worrying about the margin in lobular cancer, and that was again the consensus of the St. Gallen. Now we'll go to hormonal treatment in lobular cancer. My question to Dr. Shahla, TAM or letrozole in lobular cancer, we have this data coming from San Antonio to tell us that tamoxifen induces gene expression as partial agonist in lobular cancer in the xenograft models, resulting in more probably de novo tamoxifen resistance. That's the preclinical model, and we have in the clinic this kind of data from basic study, again, retrospective analysis of tamoxifen versus letrozole in lobular versus ductal carcinoma. It's a big big number of patients, probably the biggest. But again, it was not one of the primary endpoints or secondary endpoints. In ductal carcinoma luminal A, we don't have any difference. In ductal carcinoma luminal B, we have difference in favor of letrozole. But for lobular carcinoma luminal A or luminal B lobular carcinoma, there is a great difference for letrozole. For the preclinical model, can we really have explanation for that?
I don't really have any precise information to explain the difference between lobular and ductal in relation to the differences that they have expressed in here. I don't personally have, maybe other pathologists, they have some explanation for that.
Yeah.
Definitely, we know that based on molecular phenotyping, lobular carcinomas and ductal carcinomas are very different disease. Yeah. And even though the treatment right now isn't the same and a lot of consideration is taken for both of them, but one of the reasons that these efforts are in place to separate them is because of the fact that biologically they're different disease, and that may explain some of the differences in the gene expression in respect to resistance to tamoxifen.
Okay, thank you. So, again, the medical oncologist, would you use letrozole instead of tamoxifen in lobular carcinoma? Is this enough evidence for you?
No, I think it's not a level 1 evidence, clearly.
We'll never have level 1 evidence here.
No, we have to
a prospective study designed to differentiate this.
We have to be careful. I mean, saying that today you need to initiate just according to this data always aromatase inhibitors for lobular cancers, the answer is no. If you have the option, why not? If you have the possibility, what is most intriguing and interesting is, do we have any physiopathology behind this? And could we generate some hypothesis? And this is the key question. The fact is that what will be interesting is to go back to the SOFT trial and look if tamoxifen plus castration in the lobular subgroup do better than tamoxifen alone.
In the SOFT we find very little lobular.
Yes, you will, but you will find, but you will find in SOFT and text. That means again, if it's the case, that means that the estrogen deprivation in general, in this kind of disease, that might be a general kind of breast disease, when estrogen as the treatment or hormone treatment replacement therapy that you mentioned before in the menopause woman makes sense. So the estrogen environment might be more important in this kind of physiopathology of the disease. But this is just hypothesis and nothing more.
Yeah. We have some supporting data again from the Austrian breast cancer study group. Again, retrospective analysis. Again, it tells us that we have some superiority of letrozole. Anyway, I think we came to an end. The patient was put on letrozole, and for reasons we mentioned before, this disease of late relapse, so we had to consider the extended adjuvant hormonal treatment in these patients. Finally, I cannot thank more our experts for staying with us and giving us this very hot discussion, very fruitful discussion. Everybody, thank you so much on behalf of the audience. And of course, the audience, thank you for everybody in the room for staying late with us today, and see you tomorrow, inshallah. Thank you.